So it's really my pleasure to introduce Sasha Dublin as the moderator of this panel. So Sasha is a general internist and a senior investigator at the Kaiser Washington Health Research Institute. Most importantly of all, however, she is the co-leader, along with Dr. Bayless, of our Deprescribing Network, Research Network, Data and Resources Core. And in addition to that, she has been the leader of a really exciting and successful data harmonization collaborative program that forms a lot of the basis for what we're going to talk about today. So thank you so much, Sasha, and the panelists, and look forward to a great talk.
It's such a pleasure to be here with all of you. I'm just sort of looking out, and I don't leave the house all that much, except to go to clinic one day a week. So this is like the most people I've been around in a long time, and it's awesome. So this is really a panel about measurement. It's about using electronic health records. I hope we'll leave you with some useful information, a healthy respect for the complexity of it all, but some practical steps you can take. I'm going to take a minute and introduce other panelists. The format today is going to be, there will be 2 talks, each about 15 minutes, to share some data and some methods with you. Then there'll be 15 minutes for 2 of our panelists and discussants to give comments and share wisdom. And then there'll be about 15 minutes for audience questions and answers, because we know you'll have questions that will stump us, and we'd like to take a stab at sharing them and having group wisdom. So let me tell you a little bit about each of our speakers. So I'll be co-presenting the first talk with Dr. Phuong Pham Nguyen, who's a research associate at the University of Pennsylvania, a pharmacist by training, who also has a Master of Science in Clinical Epi. And her research addresses things like medication adherence, drug-drug and drug-disease interactions, comparative safety of medications, and deprescribing, with a particular focus on Parkinson's. The second talk will be given by my colleague, Dr. Liz Bayless, who is an investigator at Kaiser Permanente, Colorado, and is the co-lead with me on the Data and Resources Core. And then we're going to have 2 discussants. We'll have Dr. Josh Niznik, a pharmacist and geriatric health services researcher, who focuses on deprescribing inappropriate meds, particularly in older nursing home residents, and who uses Medicare, VA, and EHR data in his work. And Dr. Xiaojun Li, a pharmacoepidemiologist from Harvard Medical School, who focuses on things including optimal use of treatments in patients with complex health needs, including working on causal inference methodology, pharmacoepi, and electronic health data, and is interested in both observational studies and embedded pragmatic trials. So that's our group today, and we hope to bring you some useful information. Great, so I'll start off with our first of the 2 talks, and we're going to be focusing on measuring key deprescribing variables from electronic health data. And just to share some disclosures, this work was funded by, through the USDEN by the National Institute on Aging, and these are disclosures of other kinds of interests from other people in our data harmonization group. So we're going to talk a lot today in this panel about the use of electronic health data, and there are several reasons that a deprescribing study might want to use these data. One of the ways we use it is to find people who appear to be chronic users of medications who you might want to recruit for a study or perform an intervention on. Another really common thing you might want to do with electronic health data is see if you can measure discontinuation. And here I'm thinking of maybe discontinuation would be an outcome in your study. If you're doing a randomized trial, you're going to conduct an intervention, and you want to have a large-scale ability to see who has actually stopped. And so it would be of value for many studies to have methods that are developed, that are evaluated, that are known to work for identifying medication discontinuation at scale using really large data sets of routinely collected health data. So why would we need to think about data harmonization? There are lots of ways that we end up accidentally comparing apples and oranges or going in different directions. So for instance, there are many, many different studies published of deprescribing out there, and I'm sure you're all very aware, that have used different criteria, right? Different definitions, and this can make it hard to compare or synthesize our results. Second of all, our healthcare systems themselves are heterogeneous in the ways that we practice, the policies that we have in place, and in the data that we collect and how we collect and store them. And that can make it hard to replicate things from site to site. And then third, to sort of state the obvious, sometimes we're working with radically different types of data. So some people are primarily using orders data from the EHR of prescriptions written. Other people are using dispensing data. And there are some really fundamental differences that affect our ability to use them, and we'll talk about that in a minute. So ideally, we'd like to standardize our measures as best we can to support rigor and validity of the field as a whole. So these kinds of thoughts and concerns were what spurred us to propose this work group that I had the great pleasure and honor of leading in the last couple of years, called the Data Harmonization Work Group. And this is one of the activities funded under the USDEN main grant. We brought together researchers from 5 healthcare systems across the US to collaborate on this. And the healthcare systems are somewhat diverse. We have 2 that are integrated health systems, the 2 participating Kaiser systems, where we supply our members with both their healthcare but also their insurance. Then we also were partnering, there are 2 academic health systems involved, bringing that perspective. And then our 5th system is a US government system, a VA system. So that brings a whole new set of kind of data and policies and population. And what we sought to do in this work group was to develop and demonstrate approaches to measuring important variables for deprescribing studies across different sites with different kinds of data. And this is a list of our collaborators. We had the 2 Kaiser regions of Colorado and Washington. The 2 academic sites were University of Pennsylvania and Duke. And then we had the Durham VA. And I'd like to just thank and honor my collaborators and their wonderful teams who really dug into this work together. So I'll share a little bit of methods, and then I'll turn it over to my colleague to share results. I'm going to share with you, focusing on 2 of the different concepts we worked on. One of the concepts we worked on was how do you define chronic medication use from these kinds of data, and the other was how do we find medication discontinuation. And we needed to choose a use case, and we chose benzodiazepines and sedative hypnotics, meaning Z drugs. But we also recognize that things may be different with different drug classes, so take that as sort of the context for what I'm showing you. We loosely based our approach to that done in a randomized trial called Deprescribe that had previously been carried out that sought to help people stop these medications. And all of this work uses outpatient data about patients getting care in the outpatient setting, and our study years were 2017 to 2019. So first, we needed to come up with a definition of chronic use, and we did this first for claims data. And based, again, on what had been done in Deprescribe, we came up with a definition of requiring 3 or more dispensings. Adding together the day's supply had to be a total of 45 days or more within a 100-day period. And we set an index date as the date of the dispensing that was the earliest dispensing where the person had met both criteria. But then we had to think about how does this apply for sites that only have orders, and that is challenging for several reasons, right? So many of you know this already, but for those who don't, I want to highlight some of the key considerations. When a physician or a clinician writes a prescription, they can write the prescription and allow a certain number of refills, and that can be completely variable. And the person won't necessarily have to come back to ask for anything until they've exhausted those refills. So the person might not come back for a year to get any other order entered in the chart. And at the same time, there's no information on at all about days supply, about how long each refill is expected to last the person. And while orders have a start and an end date, the end date can be changed retroactively by events that happen after the initial order is issued. And so if you're used to working with claims data, you're kind of shocked to find out that key variables get changed over time when new things happen. It's like the fundamental tenet in EPI is you don't define a variable based on future events, but end date can shift constantly. So that is a challenge. So as we adapted the definition for orders, we made it require 3 orders within a 100-day period, but what we counted was the initial order and any permitted refills. So an order with 2 refills allowed would have counted as 3. And then we set the index date as January 1st, 2019 for everyone who met chronic use in 2018. So I'll just show you briefly the results when we applied these chronic use definitions in our sites, which some of these slides will be using alphabetical designations to anonymize the sites a bit. The sites ranged in size. Our smallest had 22,000 people age 65 and older who met enrollment criteria. That's sort of the source population where we applied the chronic use definition. Our largest site had about 130,000 people, and this was our site that had only orders data. The other sites were using dispensing data. And we found a relatively consistent rate of chronic use of these medications, ranging from about 1.5% at the least to 2.6% at the most. So then we had to craft definitions to try to identify medication discontinuation, and we took sort of two philosophical approaches. One was to look for gaps, so following the orders or the fills, was there a gap in use of a certain number of days over a 1-year follow-up? And we experimented with varying the length of the gap, ranging between 30 and 180 days, and varying whether or not we used algorithms to account for stockpiling, meaning an early refill. Then we took a second approach, was to say at a fixed point in time during follow-up, did a person appear to have continued use? Did they appear to, we would expect they would have had the medication on hand, and we varied the time point. It could be anything from 180 to 365 days. And we did a methodologic variation where we applied this 30-day halo around that fixed point to require no dispensings or orders within that halo period. So just to illustrate with a graph, on the far left, you see the dashed line representing, this is the index date when we started looking forward in time. Then you can see here is the fixed point. We're going to say this is the 180-day mark. And this is, each line represents a possible person. These are fictional. So each arrow is one maybe dispensing. So here we've got some 30-day dispensings, kind of a longer one. This 60-day dispensing overlaps this 180-day date. So clearly, this person did not discontinue. And down here we have another person who has a few 30-day fills, then a longer fill. Sorry, I've lost the mouse. But then this 180-day fill falls right in the middle of a gap. So this person under this definition would be considered to have discontinued because they wouldn't have had any medication on hand. But what if we apply a halo? So here's another person. Here's their index date. We have some fills and dispensings. And then here, they clearly are a discontinuer under just about any circumstance, right? Because they have no more refills. So they fit discontinuation even with or without the halo, they would fit. But here's a person who, they have some fills, and then they would have run out if we didn't apply the halo, but when we apply the halo, look, they refilled again right after 180 days, so maybe they're not really a discontinuer. So if you apply the halo, it's more stringent, and then you're going to say this person didn't discontinue use. Okay, we're ready to shift and see some results of this work. I'm going to turn the mic over to my colleague, Dr. Nguyen.
Okay, thank you, Dr. Dublin, for going through the consideration we had for medication discontinuation and the chronic use definition. So now I will share the medication discontinuation results we have when we apply different definitions to our data. So here we compare the gap-based definitions across the sites, and we vary the length of the gap. And as you can see on the slides, the graph show that as we move from a shorter gap of at least 30 days to a longer gap of at least 180 days, we have a lower proportion of people who discontinued across the sites. And just to mention, the UPenn data we don't have day supply, so it was not adjusted for stockpiling compared to the other sites. And here we compare the fixed point definitions with the varying times after the index date with or without the halo, as Dr. Dublin mentioned. So we go from 180-day to 1 year, up to 1 year. So if you, as you can see, the 180-day, we have a lower proportion of people who discontinue, but as we move further away from the index date, we have a higher proportion of people who discontinue. However, when we apply a halo of 30 days around the fixed point mark, we have a lower proportion of people who discontinue meeting the criteria. And so is it important to account for stockpiling? So here we have two examples from KP Washington and Duke University. So the blue is KP Washington and Duke is gray. And as you can see, if we, across the board, if we adjust for stockpiling or early refills, we have a lower proportion of people who actually discontinue. So I guess it's important to try to adjust for stockpiling when possible, because it can impact to the identification of people who truly discontinue compared to people who actually just have a gap in their refills. And so how do you think that the result will differ when we apply different discontinuation criteria using orders versus dispensing? So we thought that the use of orders may underestimate the actual discontinuation, because people may receive a prescription or an order but decide not to fill it, or they might not utilize all of the refills that were allowed. So for this situation, we used KP Washington data, because this site has both orders and dispensing data available for the same population. So we only included people who met the criteria for chronic use of benzo or Z-drug, using both order and dispensing-based definitions over the same time period. And then we look at their gap in medication use of different lengths according to both order and dispensing-based definition. So the gap lengths were varying from 30 days up until 180 days. And then we compared the results using both definitions. Here, the blue one is the order, and then the gray one is dispensing. And we ended up including 601 people meeting criteria for chronic benzo or Z-drug use with both orders and dispensing definition. And we, as we predicted, the proportion of people who discontinue actually were lower when we used order data comparing to dispensing data across the board. And as we've seen before, when we move from a shorter gap to a longer gap, the proportion of people meeting discontinuation criteria actually lowered. And so based on our findings, we have some recommendations. So when we want to look for a gap in medication use during follow-up, we thought that a gap of 30 days is probably not long enough to be confident that it is actually a true discontinuation. And we generally agree that maybe a gap of at least 90 days would be preferred. But that might vary by drug class, so it might be different when you look at chronic medication or versus acute medication. And so if we want to define discontinuation at a fixed point, we also would recommend using the halo approach, because people might have a dispensing or order close to the fixed point just a couple of days before or after. And when possible, we also recommend to account for stockpiling, because it can be impactful, especially when the gap in medication use was short. And so here are a few challenges and learnings that we have from this project. Obviously, working with orders is difficult, and there was no standard way to infer the day supply from the orders data. And so in this situation, dispensing data are much cleaner, because we can identify discontinuation and medication use more easily, as the day supply variable is readily available. And it was also difficult to distinguish between imperfect adherence and discontinuation, especially for the shorter gaps. And using our data, we couldn't distinguish between clinically appropriate discontinuation or versus unsupervised non-persistence to medication use. And if there's any reason for discontinuation by the prescriber, it wasn't always captured in orders or medical charts. So for our next steps, we are drafting and revising a manuscript based on these findings, and we're planning to write a practical how-to guide about the programming approach for this project. And we also plan to extend the work to examine restarting medications after a gap and characterize the patients who actually restart. And I guess this is the USDEN website, as Mike mentioned before, where you can have you can find a lot of resources about deprescribing and joining the network. And with that, I want to thank all my collaborators in the data harmonization work group for making this project possible. And that's it. Thank you.
Hi, everybody. I'm Liz Bayless from Kaiser, Colorado. Can you hear me okay? Okay, great. And thank you all for coming and for putting up with a couple of presentations right before lunch, but we are getting there. What I'm going to talk about is a project that we have been working on at KPCO and at Johns Hopkins. Cynthia Boyd and I have been collaborating on a number of deprescribing efforts over the past several years. And this project, which is called GEODES, Generating Evidence on Deprescribing Safety, is a methods development project that is very messy, so we're going to share some of that mess with you. And it emerged from a deprescribing education trial called Optimize that we have conducted over the past 5 years. And what happened during Optimize, which was this great project, is that NIA asked us to have a data safety monitoring board, a DSMB, and to develop methods for safety monitoring in the context of this deprescribing education trial, which we had not originally conceptualized in the grant. So we patched it together and discovered that there's a lot to be learned about the safety of deprescribing education and how to measure it. And a lot of the difficulty and messiness in measuring has to do with how do you identify people who stop medications. So that was the starting point for this trial. Not really a trial, this methods development work. It's also funded by NIA. It's under a separate grant mechanism, as you can see there. This is the team that we have. It spans the globe, as all good deprescribing work should. And then this is some of the background that I started to talk about a little bit earlier. Sarah, I couldn't agree with you more that part of what we need to do in this translational spectrum is develop the evidence at the beginning. And we often do work with big observational data sets and clinical data. And so while it's not going to have the precision of efficacy evidence generation, being able to generate evidence and look at safety at scale is sort of where we were trying to go with this. And part of that is trying to figure out how do you measure stops with electronic clinical data. Traditionally, gaps in dispensing have been used as a proxy for stops, and usually that's 90 days in the deprescribing literature. But nobody thinks that 90 days really represents true discontinuations for everything, and so we thought we would try to understand the misclassification that can result from using gaps in dispensing. This is all done with dispensing data, by the way. So our initial approach was to identify individuals who have a 90-day gap in dispensing of chronic medications and then try to see what's underneath the hood of those 90-day gaps. We did not try to create a representative sample because we're really trying to understand what's going on in these various clinical situations behind the 90-day gaps. And I should say at the beginning, and I'll come back to this again, that our long-term goal in this project is to go beyond what you're going to see here and to use all the information that we gather from this work to develop a text string search natural language processing approach to identifying medication discontinuations from clinical notes, not relying on dispensing data per se. So that's the reason for the non-representative sample. We have done a lot of medical record reviews that we'll talk about, and they classify medication records into true and non-discontinuations, and then look further into the circumstances that characterize each of those buckets. And then we're going to use those two big groups of records to develop as the gold standard cohort for developing the NLP basis. So we have focused on 5 different groups of medications to do this. So the medical record reviews sample from all people who are taking all of these different groups of medications, and you can sort of see why we chose them. We wanted to try to touch on the different clinical indications for deprescribing, possible different reasons for experiencing adverse drug withdrawal events should they happen to be discontinued, and to really get a sort of a broad picture of what might be going on, how to characterize stops using clinical notes. This sketch is the sort of outlines the timeline that we used for reviewing the records. So I described the starting cohort just a minute ago. We looked at people who had a 90-day gap in dispensing of a chronic medication from one of those groups. And then we continued to observe what happened during the subsequent 120 days after that 90-day gap in dispensing. So they would use up their day's supply, have a gap in dispensing of 90 days, and then we would look for another 120 days. In that 120 days, we did include people who had re-prescribed or restarts of the drug group in question, and those who didn't. What we found is that of the ones that we were looking at, about 60% of the 2,000 charts or so that we have reviewed to date did in fact seem to reflect true discontinuations. And of those, you can see these various categories that we have sort of created sub-buckets for. Provider discontinuation accounted for about half of them, and we placed a heavy emphasis on intent. So when there was clearly intention of a provider of some kind to stop the drug, then that counted for us as a true discontinuation. If, for example, the provider intended to substitute one drug with fewer side effects, for example, for an initial drug, we counted that as a discontinuation. Sometimes there were clear stops and restarts. And then you can see there's an additional batch of somewhat less common but still important categories, such as when a patient discontinues a drug and the provider intentionally agrees with them and says that's a fine idea, let's stop it. Or speaking about collaboration with subspecialists from primary care, for example, when a colleague discontinues a drug and we were focused primarily on primary care subsequent action intention. Then about 40% of those with 90-day gaps in dispensing really did not seem to reflect intended discontinuations at all. Often we found situations where the provider might change the formulation of a drug to an extended release, for example, but really had no intention of stopping it. Sometimes there was a pharmacy procedural change that I think is probably much more likely in our integrated system, where the vast majority of the dispensing occurs within Kaiser pharmacies. And so the pharmacists have some leeway about matching prescriptions to formulary availability. There was, unsurprisingly, quite a bit of low adherence that resulted in those 90-day gaps. And then there was about half of the 40% that we noticed. When we did these extensive record reviews, we really didn't find any evidence of stops at all. There was no intention to stop. The drug remained on the med list. There were no, as far as the provider was concerned, it continued. And so there was just this gap in information there. This is a little plug. Check out Jonathan Norton's poster for all the details on the work that we have done with these record reviews. It will be on display this afternoon. So the next part of this little description is going to focus on what we found in terms of factors affecting misclassification in situations where that 90-day gap really did not reflect a discontinuation. Unsurprisingly, when true discontinuations were much more likely when there were no further restarts, when that 180-day period did not have any further prescriptions. True discontinuations were also more likely when there was a longer complete, these sort of say the same thing, but basically the longer someone's really off, the more likely they are to be truly off. Then there were some factors that we found in our measurement category that made it very difficult that also can affect misclassification. For example, situations where there's a lot of titration between drugs, and Dr. Hilmer, when you were talking about how substitution really didn't seem to reflect deprescribing to you, this is what I thought about, which is when there's one statin exchanged for another statin as part of treatment intensification or something like that. We think that that's something that can often contribute to misclassification and measurement. Using certain drugs as needed, such as proton pump inhibitors, it was very, very difficult to figure out whether those were truly discontinued because patients will often acquire a large supply and use them as they need to over a long period of time. Drugs that occur in combination, which is very common with antihypertensive drugs, were an area where we found we had to sort of make up the rules as we went along for how to count these. And you can see 3 examples here of how combination drugs can be either discontinued or continued and look like stops. And so we found that we had to, in our measurement sort of algorithms that we developed, we had to consider combination drugs really as a separate class altogether, and then make a lot of coding adjustments to account for when that class resulted in a continuation, such as case number 1 there, or a discontinuation, continuation, such as case number 2, or a discontinuation, such as case number 3. A couple of examples of clinical text that we are finding from all of these record reviews that's going to inform the NLP development. Specific terminology is obviously very helpful, and you can see examples here. Change to this drug, stop this drug. Both the positive and negative examples are going to inform the text strings that we're in the process of developing. And we think that ultimately the way that the text string approach plus the data approach will work is to combine the two into some kind of data-based algorithmic approach, plus using text strings to really optimize specificity and sensitivity. And this is a fairly simplified version of what we're starting to explore, but we're using, say, the text string approach to find records that are most likely discontinuations based on text. And then we're supplementing that with data-based algorithmic approach to find examples where, for example, the reason for discontinuation in the electronic health record is allergic reaction. And we found that that's actually highly predictive of a true stop. Whereas if the reason for discontinuation in the EHR order says something like, pharmacist is stopping this to continue a new prescription, then that's very unlikely to be a discontinuation. So optimally, we'd like to be able to combine the text string application, both positive and negative, with certain database criteria. And in our early work so far, doing this with the diabetes group of drugs, in both a test cohort and a validation cohort, we're at about 80% specificity and sensitivity, and which seems not perfect, but not bad. And we think that that's going to need to be tweaked a little bit, obviously, for the other drug classes, especially things like combination drugs and antihypertensive treatment. So here are some conclusions before we discuss all of the applications of this work. The 90-day gap in dispensing, I think, probably overestimates medication discontinuation, and we've only been able to explore one side of the bias associated with that. Ensuring that there are no further fills after that 90-day gap, which basically means extending the 90-day gap further, obviously increases the likelihood of true discontinuation. Different medication groups are going to require their own rules. Developing an approach for as-needed drugs, such as PPIs, is going to be entirely different from, for example, the diabetes group that we've started doing our initial work with. And understanding the documentation associated with all of this work, I think it's a very iterative process, right? So that we can use the documentation assorted with the work to inform the development of the data-based approach and so on and so forth. So hopefully the combination of the two can get us to a point where really we can identify discontinuations at scale in large populations, and then subsequently, this is all about the exposure. And then we can go on to look at outcomes using observational methods. So I will stop and then let our panelists comment on some of the methodologic applications of this.
Thank you so much, Liz. So now we'll have about 5 minutes of commentary, discussion, philosophical musings from Dr. Joshua Niznik and Dr. Xiaojuan Li. And Xiaojuan, would you like to start us off?
Sure. Thank you, Dr. Dublin. And I would like to first thank Dr. Dublin and Dr. Bliss for inviting me to participate in this panel discussion on how to measure these key variables in deprescribing research. As having been said many times, that measuring those variables is key in this deprescribing research. However, it is very challenging to measure these variables, left alone using imperfect data. So it was great to see the impressive work conducted by both groups, which is bringing us closer to answering those questions. In my view, I think there, on the high level, I view there are three key things that are related to measuring this variable, the three key questions I keep asking myself about this. So the first one is what to measure, what kind of metrics are we going to use to measure these variables, and second is how to measure them. And the third one is actually how do we analyze them once we measure them. So all these three things are, I think, interconnected and also intertwined, so which is making this problem really complex and difficult. So with respect to the first element on what metrics to use or what metrics to measure, we have heard from the previous talks and also panel earlier and the keynote. I think medication discontinuation or deprescribing is quite a process. We have learned from both talks about measuring discontinuation as a dichotomous measure. However, this may not be the only measure or the only action that clinicians actually take when it comes to deprescribing. So there are different drugs that may be doing de-intensification, so maybe tapering dose reduction rather than stopping right away. So I think I would like to encourage the group and also everyone in the room to also thinking about algorithms that extend beyond the dichotomous measures, such as continuous measures or other categorical measures related to dose reduction and things like that. I think that will be helping us to capture a wider range of the reactions of the clinicians. And also it's worth noting to think about or define this dose reduction or these variables upfront about whether it's discontinuation with respect to the agent or with respect to the drug class. As we have seen, it could be actually, I think as noted by Dr. Bliss, that it could be a misclassification when it comes to switching between the same drug class, which may not be actually a discontinuation. So I think that would be also important to think about, which is clinical context and drug dependent. With respect to the second element I mentioned, which is how to measure this, once we identified what we want to measure, I think this is a multifaceted question, which I think is the whole talk panel about. I think it involves at least three key elements to think about. First is the clinical setting where our studies are embedded, whether it is embedded in a health delivery system which has EHR data, and whether it's embedded in health plans, which we only have access to claims dispensing data, or whether we actually have both, like Kaiser, this integrated health systems. So this will determine the type of data we have. I think for us to actually to conduct these studies or measure this, we actually need to evaluate whether the data is fit for purpose, borrowing this terminology from real-world evidence, real-world data. I think we need to evaluate whether we have the amount of data, whether we have the appropriate type of data, and also whether we have enough, whether it's deep enough or actually longer enough to evaluate this kind of measures. And also whether we have orders data or claims data, as noted by the first talk, that orders data comes with a lot of challenges. You may not have information on days of supply. So you have to actually do these kind of adaptations to when you use AGS data. However, it may actually be more direct, reflective of the actions done by clinicians. So I think these considerations have to be taken into. Lastly, I want to mention that the third thing that I want to see that is operationalize these definitions within the data you have, that we have, that we want to actually thinking about all these technical details, whether we do stockpile, and we've shown that actually stockpiling will be important, but also when do you start looking for the data to start the stockpiling process? That's also another key element we have dealt with in our studies as well. So closely related to the second element on how to measure, I think, is also the implications of these definitions when it comes to study design and analysis. This will also matter whether you are measuring this as exposure or outcome. There are multiple elements. In the interest of time, I'm going to just highlight one element, which is the anchor date of this event. So we're using future, some follow-up information to actually define these variables. Choosing the anchor date appropriately will help us avoid or mitigate the potential bias that comes to it. So I think overall, I think it would be great to see some guidance on how to conduct this kind of measurement in studies, whether it's for non-experimental or experimental studies. I think the great work we have seen in these studies that brought us closer to that, and there are a lot of lessons learned that can be valuable for those studies. I think ideally we want to have some kind of standardized or validated algorithms for measuring discontinuation in studies. However, one size fits all may not be possible or appropriate here. As we have seen, it will be drug class dependent and also clinical context dependent. So I think instead of having one measure or a couple measures, but just thinking about a general framework that can guide us how to measure this kind of variables in these studies will be really, really helpful. And I would encourage the group and the team in thinking about how to get there. And I would looking forward to discussions and further thinking about how we can get there. Thank you.
Thank you so much. That's super interesting. And then Dr. Niznik will weigh in with some thoughts and reactions.
Yeah, so covered a lot of great points already. But I think one thing that I've been thinking about, even in my own work, prescription refill data, prescription order data, there is a lot of research out there that has validated these data sources against other data sources in terms of prescription adherence and whether patients are actually taking their medications as prescribed, right? So there's been studies comparing prescription dispensing data against patient self-report, against electronic medical records, and I think on the whole, we know that those data sources generally agree pretty well, but I think what we've pointed out here is that when it comes to stopping or deprescribing medications, there's really kind of no research that has looked at that piece at all, which is inherently very different because there are so many different players and so many different opportunities and also pitfalls for identifying deprescribing. I think in a lot of cases, those of us that use prescription refill data think, oh, it'd be great if I could link this to the medical records so I could go in and figure out what happens. But the reality is, and for those of you that stopped by my poster earlier, you know that the medical record isn't necessarily that great either. There's a lot of inconsistency between providers, between systems, between different clinics. And so I know that, in a lot of cases we consider that to be the gold standard, but is that actually the gold standard, or is that just another maybe less biased source of information? So I think it's important to think about what you're getting out of a different data source if you're going to be combining them, and how much it's helping or potentially hurting your cause. One thing that hasn't been discussed that I think is kind of interesting and comes with different advances in technology, and as more systems have Epic or other electronic medical records, is the opportunity for customized data elements, particularly for not observational research, but more like pragmatic implementation trials, and whether there's an opportunity there to leverage some of those customizable data elements to validate some of the data from prescription orders and prescription refills. So for example, one of the studies I worked on at UNC, we were using prescription order data, and we knew that that was a limitation going in. So as a kind of just a test, we developed a bunch of different smart data elements that the pharmacists who were delivering the intervention implemented, and that was stuff that we could pull on the background to cross-check against prescription orders. So for a trial that's maybe a little bit more pragmatic, or you have a health system or a partner that you can implement those kinds of things, that may be another useful resource for validation as well. And then finally, to the last point that was made, I totally agree that there's not a one-size-fits-all approach. I know that we all want like a consort checklist or whatever of like, you should do your deprescribing trial this way. But the reality is that, different data sources, even electronic health records, are all designed differently. And so I still think that there is value in building in either an AIM 0 or an AIM 0.5 to spend the time to do some of that validation work for your definitions up front, and that rather than a list of you should use this gap because it's the most accurate, it should be, what checks did you do in your data to make sure that what you're presenting is actually what you're saying you're presenting. So how many different definitions did you check? How did the prevalence of deprescribing change when you used those? Did the association with your confounders change when you did that? What other data sources could you have brought in to potentially validate those? Did you do any sensitivity analyses? So I think that kind of approach, just making sure that it's a thorough evaluation of the data that you have, is probably going to serve us all best moving forward. So, thanks.
Thank you so much. So now it's all of your turn. We would love to hear your anecdotes, your questions, your challenges, and we will do our best to give thoughtful answers, if not one-size-fits-all answers. And please state your name and your institution so people can get to know each other. Please go ahead.
Hi, Kaylee Hayes from Brown University. I think I've had the pleasure of having individual meetings about deprescribing measurement with all of you. So my question is about kind of your thoughts on principles to follow when deprescribing is the outcome versus deprescribing is the exposure. Because I do a lot of drug effect studies, which observationally are difficult to do with deprescribing as your exposure. But it's kind of like, okay, we just see that they're off the therapy for long enough that it's out of their body, and then if they restart, we'll just censor them. But there's other principles that kind of guide that. But in terms of just generally deprescribing as an exposure and outcome, what are your thoughts on that?
Anybody want to take a stab?
I mean, I would say you should follow the same principles as though you were initiating a drug, right? So has this person been exposed to deprescribing long enough to have the potential for negative events? So in the way that you said, Kaylee, I do think that there are different implications depending on when deprescribing is the outcome versus the exposure in terms of whether you may want to prioritize sensitivity or specificity. So, for example, when deprescribing is the outcome, you may want to prioritize specificity so that you can accurately characterize the rate of deprescribing, what factors are associated with that. But the more specific definitions that we have, as we saw, require longer periods of observation, which limits your sample size and makes it less generalizable. So you really have to weigh if you're willing to take the hit in terms of accuracy in order to preserve the other components of your study. So I think that's exactly right, that there are different implications depending on how your study is designed, which again necessitates kind of a targeted approach for evaluating all those different facets. Yeah. I don't know, Xiaojian, you have?
Yeah, I totally agree with what Josh mentioned, and also just want to add to that, especially when I think we actually saw two different ways of defining deprescribing or discontinuation. One is the fixed point method with the halo, and the other one was the gap method. This method is requiring different length of follow-up, and also the amount of time they are going to use. There's a potential for immortal time bias depending on how you are going to handle it. That's linking back to what I mentioned about the anchor date of the outcome, which will be more important than when you are thinking about exposure, which should be easier to deal with. So I think that's another thing to thinking about which method you're going to use when it comes to study discontinuation as an outcome that will try to minimize your bias or selection bias that may arise from the different definitions.
Thank you so much. Topic that could use an entire session of its own, I think. Yes. Thank you. Please go ahead.
Hi, everyone. My name's Wade Thompson from University of British Columbia in Vancouver, Canada. First of all, amazing work, super interesting, sorely needed. So congratulations to everyone on the panel. My question maybe more relates to deprescribing or discontinuation as an exposure. And I'm wondering if in any of the work that you have presented, you were able to nail down the timing of when discontinuation or deprescribing actually happened, because we're using things like gaps, but even if we're using a gap or an EMR, did you ever investigate knowing when exactly something got stopped? Because I'm thinking about a benzo, for example, it's probably important to know exactly when versus for a statin or something, maybe having 30 or 60 days where you don't exactly know is okay, but just wondering about that.
Yeah, I think that's a great question, and it's sort of as a segue into maybe next year's conversation here, but what we're, in some of our record reviews, we have been able to identify the date on which the discontinuation was, at least when the intent was articulated and the medication was stopped, and what we hope to do from those precise, the better understanding of those precise dates is actually try to understand whether adverse drug withdrawal events might occur in the wake of that. Mm-hmm. And so getting that date right is really key, because a restart of the medication within a relatively small window might actually indicate an adverse drug withdrawal phenomenon of some kind, making the precision of that date really important. And so we've been only able to do it so far. This is so exploratory for us, but we've been doing it with the record reviews so far. And then we hope to develop a sort of a parallel process using the natural language processing and some dates of dispensing and whatnot to come up with a fairly precise date so we can look at outcomes after that.
Okay. I have a second question, but I think there's more questions, so I won't ask.
So I just want to make one comment in response to that. I think your question is absolutely right on, and it's one of the things. So my primary training and entry into this field has been as a pharmacoepidemiologist for about the last 15 to 20 years. And this is what worries me the most about us trying to define exposure in this way, because especially with something with a 90-day fill like a statin, by the time you see that it has been stopped, it could have been 88 days. And so what do we do with those adverse drug withdrawal events that happen in the first 5 days, 10 days, 20 days? It's sort of like the whole WHI thing all over again, that we miss the events we care most about, we are going to miss. And so I think this is a huge cautionary area, and I think if we all put our heads together, we may be able to come up with some use cases that work, but I'm really worried that we're going to miss the critical windows because we can't detect a stop until it's almost too late, and then we have sort of survivor bias of the people who have still stayed off of it are the ones who didn't have the adverse drug withdrawal events. So you're asking the most important question.
Thank you. Again, Gina Upchurch with Senior Pharmacist in Durham, and I'm adjunct faculty at UNC Public Health and Pharmacy, so thank you for being here. Quick question. We heard the last panel, there's frustration, indications not on the prescription. Why stopping a prescription, and you've got this prescribing data, and then you've got the pharmacy data, there is somebody in between the two that's doing the communication. I think it's called the switch company or something. Somebody can talk about this a little bit more, but the information that comes from the EHR, electronic health record, where you're prescribing it, and then the pharmacist receiving it and dispensing it. There's a connector between the two. Who is that? I'm also I'm one of the pharmacists on the public policy committee for AGS. So just talking about where the power and the money is, why this data is so complicated. So is there a group that connects the two? I think it's called the switch company. I may be wrong. I may be thinking about Part D down the line and adjudicating claims. And who holds that connection between the two? And just like we're saying, there should be a law that says you should have the indication on the prescription. Maybe there's something that says that connection needs to happen and that data needs to be more available. I'm just curious if anybody knows. And I thought there was some data that around the electronic health record, people are having a hard time stopping prescriptions. So is there any legislation to encourage stopping prescriptions with that switch company? I'm just curious if anybody knows.
I mean, I'll just respond with a few thoughts. One is that I think Liz and I have the great luxury of working in a healthcare system where we're not allowed to sign an order without putting in an indication. When Kaiser chose to operationalize Epic, they put in that requirement. I think they didn't for the first couple of years, but I would encourage you all to lobby your healthcare systems. Your healthcare system can make this choice to tell your EMR vendor you want that in there. And so I think that's really helpful and important. It doesn't mean that indication's accurate. I also don't know about a switch company, but at Kaiser, I'm stopping an order that my own pharmacist is going to fill, and I have to right-click, and then I'm offered a chance to say why I stopped it, but I think I'm allowed to leave it blank. But there's a very clear action that I take to remove it. The problem is the patient might have stopped it 4 months ago or a year ago, and until they come in and see me, I don't touch the EHR. So it doesn't 100% solve it. Does anyone? I think we can go a tiny bit over. Cynthia, let me know that as lunch is getting set up, we can keep talking while lunch is getting laid out for us. So
I would just say that I think the switch, or whatever you want to call it, is probably highly system dependent. Yeah.
Noel, please.
May I continue?
Yes.
Excellent. So that's a great segue.
Go ahead and introduce yourself.
Yes, Noel Campbell, Indianapolis, Indiana, Purdue University, IU Center for Aging Research. As a user of order data, out of necessity, not out of preference, I want to raise the question of missingness of order data, right? So it's a challenge that we're all dealing with when using order data. We've been able to find those patterns in some of the free text fields and identify or decrease the level of missingness from around 60% to 20%. But we've done that in our N of 1 case. And so my question to you, and maybe request of you in this work that's progressing, is the question is, in your multiple sources of data, was missingness consistent? And secondly, if not, how did you address missingness through imputation methods or other methods to access certain data fields that would be helpful to others? And the request being, can we put that as part of our lessons learned, so we standardize how we're addressing missingness in these data sources, so that we can talk apples and apples?
Noel, can you elaborate a little on what is missing? And when you say, like if I don't see an order for a benzodiazepine, I'm not going to ever think someone's a chronic user, so they'll just be missing. But I don't think that's what you meant.
Correct. So certain fields. So when I go into our health system and extract order data,
yeah,
I expect to see name, strength, pills, number ordered, day supply, which we already addressed, is not there. It's never there. But things that you think should be there to make a prescription legal, and Gina, this goes back to your point, strength of the medication. To be a legal prescription, it has to be there when it goes into the repository, but when I pull it out, it's not there, but it's part of a text string called order details. And that I have to figure out how to unpack. And that's the moneymaker for us, is how do we get in there, tease out all those elements in the pattern that they're commonly limited. How do we tease those out? But it's all in there. It
Yeah.
just gets manipulated from when it goes in and when it comes out.
I think you might be talking about what we call SIGs. And
Yep.
you know, when I first came to Kaiser in 2007, I think we somehow didn't have day supply or something, but there was a period before day supply. So we also have prescriptions going back to 1979. So we're using data that were built before SIGs were either captured or existed, right? And so we learned a lot about working with those, and part of what we learned is that they're fairly health system unique. And that sometimes they're encoded in these bizarre patterns of letters and numbers. And we just had these incredible, super experienced old school programmers who knew what we were doing. But I think you're right, but I don't know that we're going to be able to come up with principles that work that are transferable between health systems.
Okay. We may not. And again,
Yeah.
the variable that we're trying to construct may not be the same variable that somebody else needs
It's
with the
true.
same type of missingness. I do think that there's an opportunity here for best practices, and this is the group that can
Yeah.
come up with that, is how do we
Yeah.
handle missingness that still
Yeah.
applies to the clinical
Yeah.
intent of the data as it was used.
I definitely think we have time for one more question, but this will be our last. And I just want to point out that table number 4 is a data and measurement table for people who really want to keep talking. Can we do one more question?
Yes, one more question.
Yes, one more question.
Hi, Connie Funk from UCLA in Via Greta, Los Angeles. I've been conducting a couple trials deprescribing benzos and Z-drugs, and have noted that there's a lot of, I wouldn't call it non-adherence, and it's not really early refills. I mean, there's just a lot of patterns, and even within a patient, they can really change their pattern of use over time.
Yeah.
So you alluded to this a bit with your comment about PRNs in PPIs, but I'm just wondering, how are you incorporating this in some of the presentations on benzos and Z-drugs? And it's not, I mean, they're not necessarily PRN. It's just that they don't use it every day, but they're still getting, it's quite common to get a 30 tablets for 30 days. Can you elaborate on how you've accounted for this in your discontinuation?
Yeah, I mean, I think you're bringing up an important point, and one that we definitely thought about and chewed on and talked about a lot. I don't know that I have a really satisfying answer. I mean, that was a big part of why we only required a total of 45 days supply for a 100-day window, because we thought that we didn't expect people to be using benzos every single day. But that's in our chronic user definition. The other thing we recognized fairly late in the project that I think needs more work and thought was that when a physician in our system does a careful, thoughtful taper, they continue to write the same day's supply, and they just give less pills every time. So a metric that just looks at days supply is actually going to miss a really important taper, because the person is still getting a 28-day supply month after month after month, but instead of 56 pills, it's now down to 14 pills, and if we only look at days supply, we're missing all the action. So I think you're bringing up a really good point. I think that the only maybe thought I have right now, which is probably not very satisfying, is that for the more sporadic use, I think the longer the gap you choose, like the 90-day gap or the 180-day gap, is gonna give you a lot more security that someone has truly discontinued, and the 30-day gaps are gonna really not be helpful. But that's not really getting at the nuance of what you're raising.
What it makes me think of Josh's comment about defining your variables very carefully and doing some validation work at the very beginning to make sure you know what you're working with, because of all that nuance and variation.
Thank you.
So thank you so much to all of you for your
Yes,
interest
thank
and
you.
attention. And